A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9:15 to 9:45 am for you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. And these are to improve and maintain the standards of the CPD programs conducted by Tree Knowledge Academy. So today's topic is the prudent use of antimicrobials in human medicine. You can ask questions at the end of the webinar. The guest speaker for today is Dr.B. Devakanthan, consultant microbiologist at the Teaching Hospital, Batticaloa. Over to you, sir.
So thank you very much. I would like to thank President, Secretary of Sri Society for Health Research and Innovation, Dr. Vas and Dr. Samira for giving this opportunity to deliver this presentation. And my sincere thanks to Dinukshi and Manashi for coordinating this event. Actually, long weekend, Sunday morning at 9:30, 77 participants is really amazing. So 78 now. So very good. I'm very happy to deliver this lectures. So my topic today is prudent use of antimicrobials in human medicine. You know, antibiotic is life-saving medicine, and most of the intervention in modern medicine became realistic because of antibiotics. However, dilemma of dispensing antimicrobials or antibiotics still persists in this modern microbiology battleground. Prudent use of antibiotic is very important to save patients and preserve antibiotic for its future use. Shortly, I will talk about antimicrobial resistance as well. So, prescribing antimicrobial is not an easy target. At least you have to spend 3 to 4 minutes to decide an antibiotic. So, wrong antibiotic, it can lead to sepsis, multi-organ failure, side effects, antimicrobial resistance, and death. Prudent use, of course, is life-saving, but you have to consider so many factors. So this very important topic, that's why when he asked, I really agreed. So, and I'm happy that a lot of doctors are here. So today I'm going to talk about introduction and fever, introduction of antibiotic and fever, because I put 2 or 3 slides about fever, because, you know, when patient presents with fever, he always think antibiotic. So that's why actually I put for a few slides about fever. And organized approach for confirmation of infection and management. We are going to confirm infection and management, then only we can prudently use antibiotic. And what are antimicrobials? Choosing the correct antibiotics. What are the factors to be considered? The dilemma of dispensing antibiotics, and summary. So, introduction. You know, Alexander Fleming, he discovered penicillin in 1928 and introduction of penicillin in 1940s, actually, which began the era of antibiotics. Before its introduction, there was no effective treatment for infections such as pneumonia, gonorrhea, or rheumatic fever, and hospitals were full of people with sepsis contracted from a cut or scratch, you know, during 1940, means Second World War time. And doctors could do little for them, but just wait and hope. So after 1940s, after introduction of penicillin, actually, this death rate, actually mortality rate improved. And after that, they discovered a lot of antibiotic until 1985. And antibiotics have helped to reduce global deaths from infectious disease by over 70% since 1942. So how it acts antibiotic? So antibiotics mean it's against bacteria. Antimicrobial mean we include antifungal, antiviral, antiparasitic agents as well. So if you take a bacteria, it has a cell wall, it has a cell membrane. Cell walls are outside layer, cell membrane, and it has cytoskeletons, nucleic acids, ribosome. So there are so many structures are there. So this antibiotic, some antibiotic is breaks the cell wall and let organisms swell and rupture. And some antibiotic breaks the cell membrane. And some antibiotics is break the cytoskeleton, like our bone, like rib and other bones. The organism also has cytoskeleton to maintain the shape. And some antibiotic, it breaks the nucleic acid, inhibit the synthesis, and some antibiotic inhibit protein synthesis. Right. So this is the mechanism of action. So they introduced penicillin in 1940s, and after that, a lot of antibiotic came into the market. Then what happened? After exposure, organisms started to develop resistance due to selective pressure, favors the growth of antimicrobial resistance. There are so many mechanisms. So once exposed, it will alter the DNA by mutation. So with other mechanisms, it became actually resistant. And here, say, and natural selection also, it happens. So here, if we take this brown color part as this oval shape part as a bowel, so in our bowel, there are millions of organisms. And nearly 90% we have natural floras. And we have resistant floras, each of us, because all are doctors and we have already exposed to hospital environment. So definitely we have resistant bugs such as carbapenem resistant organism, very virulent bugs. But here, this normal natural floras, it won't allow these resistant bugs to adhere on the bowel surface. So it can't translocate or it can't cause infection. So what we do, 2 decades ago, people thought meropenem, it does wonders, and when patient present with fever, they put patients on meropenem. So meropenem is a broad spectrum antibiotic. It doesn't have target. It kills all organisms. So what happens? It kills all this natural flora, but unfortunately, only this bug is resistant to meropenem. So it's selected. Then it will become dominant bacteria, and it will start to grow. And easily, it can adhere to the surface. It can translocate, and it can cause severe infection, mortal grade as well. We'll talk about it later, about this CR or carbapenem resistant organism. So very, very careful. So prudent use of antibiotic not only save the patient, to save antibiotic as well for our future use. That's why I already told you, after 1985, there's no new antibiotic. After 1985, a lot, but after 1985, no. So this mechanism of resistance, how it become this one resistant to antibiotic. So these organisms, by changing the nucleic acid, it decrease uptake of this one antibiotic. And some organism, for example, Pseudomonas, it forms efflux pump like our motor. But what happens when, for example, when meropenem enters into Pseudomonas, into that cell, what happens through this efflux pump? It throws that meropenem out. So there's no enzyme, just pump is there, only specific for meropenem. Just I'm talking about example. But this Pseudomonas is sensitive to ceftazidime, sensitive to piperacillin tazobactam, sensitive to most beta-lactam antibiotic, but resistant to meropenem because of this pump. So it can happen. So when you interpret report, careful. Don't say, oh, meropenem, this bug is meropenem resistant, but they report as ceftazidime and other piperacillin tazobactam sensitive, so it's wrong report. No, it can happen because of this pump. And organisms, it has inactivating enzymes. So once drug come into this one, so it can inactivate that drug. So there are lot of enzyme. For example, one is very virulent, one is beta-lactamase. So alternative enzymes are there. Target site, simply it can alter the target site. So if we expose this one to erythromycin, but it can alter the target site, and once alter the target site, it will become resistant to clindamycin as well, just for example. So this antibiotic resistance is highly dangerous actually. Right. So antibiotics, so penicillin they introduced in 1940. Before that, sulfonamide was there, but they actually came to the market in 1940, actually, after penicillin. So 1914, they introduced penicillin. Within 5 years, it became resistant. Early initial 1 or 2 periods, all recovered, but within 5 years, it became resistant. Then they introduced chloramphenicol, and it became resistant within 10 years. Vancomycin, they introduced in 1955. After nearly around 40 years, it became resistant. Like that, say, on top you can see antibiotics, and below when it became resistant. Right. So resistant to many key antibiotics, actually ciproflox, levoflox resistance is very high. I'm very sorry to say, sometimes I saw a few prescription, even just for viral fever, prescribed ciproflox, levoflox. So, not only for resistant, this one, levoflox, ciproflox, actually is a second line antibiotic for tuberculosis. So if we just expose this levoflox, ciproflox, and thing is 25% of our population has latent TB. Even if 4 of us are here, one definitely should have this, according to the research, latent TB. So if we expose this levo and cipro, what will happen? So that TB will become resistant to levo and cipro. Mainly we used levoflox. It's CAT2 treatment. So if it becomes resistant, we can't use. So highly dangerous. So we have to use antibiotic prudently, and we should think about these resistant mechanisms as well. And as I told you, after 1985, there's no antibiotic. Now, what they produce, long ago, 45, 50 years ago, they introduced ceftazidime, and they introduce avibactam as well. What they do, they combine and they release as ceftazidime avibactam, meropenem, valbactam. So now we are receiving combination. They introduce combination of antibiotic, not new antibiotic, unfortunately. So we have to use these antibiotics very, very carefully. Actually, I took this opportunity to tell about this resistant mechanism because it's very important. And every year from 18th to 24th of November, we celebrate World Antimicrobial Resistant Awareness Program. So last time we covered a lot of doctors. So here also nearly around 87 doctors are here. So actually I have taken this opportunity to tell about this awareness and how to prevent antimicrobial together, right? Right. So now we'll move to fever. So fever, fever is defined in multiple ways. It's an isolated core body temperature more than 38 degrees or 2 consecutive elevation of greater than 38.3 degrees centigrade. So what is happening here? Right. So fever, when patients present with fever, we always try to start antibiotic. So I worked in Western Province, Central Province, Southern Province, Eastern Province, and in the UK as well. Not only in Sri Lanka, in the UK as well. When I go to ICU, junior doctors, they ask, sir, this patient underwent thyroidectomy, day 2. He's spiking high spike temperature. He's spiking temperatures. Height is nearly around 103, 104. But inflammatory markers are normal, hemodynamically stable. what antibiotic you would suggest? Because he's spiking temperature, what antibiotic you would suggest? So, do you prescribe any antibiotics? Anyone? Because this is inflammatory markers normal, and if patient is hemodynamically stable, we have to think about other causes of fever. Manashi, can you hear me?
Yes, sir.
Can you hear me?
Yes, sir.
Yeah. So we have to think about other causes of fever. So other causes of fever mean fever between 38 to 38.9 degrees centigrade. We have to rule out DVT, pulmonary embolism, superficial phlebitis, GIT bleeding, pancreatitis, bacteria. So post-operative fever possible, post-transfusion fever possible, subarachnoid hemorrhage, ischemic bowel anacrotasis, MI. Can be anything. Can be anything. So when patient spiking fever, if you start broad spectrum antibiotic without any target, so it's not good for patient and it's not good for antibiotic as well. So infection is possible. Yeah, ICU patient, there's a possibility of VAB, catheter-associated sepsis, then negative sepsis. There's a possibility, but we have to rule out other causes as well. So when consider infection, how we are going to confirm that infection. So there's an organized approach should be there. Then only we can use the antibiotic prudently. Otherwise, we can't use prudently. So what is that organized approach? We should take a very good history. It's very important. History, by asking history, you can rule out a lot of infection. Physical examination, diagnostics test, marks obvious path. But problem is sometimes a thorough history and physical examination can be hindered by uncontrolled elements, such as altered mental status, and results of diagnostic can be equivocal or even false. So we have to be very careful when we take history examination findings. So as I said, yes, this history, physical examination, relevant demographic information, medical history, laboratory data, results of diagnostic imaging, all are important, and a good understanding of surrounding epidemiology. So what is that? Good understanding of surrounding epidemiology. So for example, in our ICUs, for Sri Lanka in our ICU, Acinetobacter infection is very high in ICUs. And a lot of people actually die because of this multi-drug resistant organism, Acinetobacter. I think nearly around 35 patients die per day because of purely due to multi-drug resistant Acinetobacter. It's resistant to all, only sensitive to tigecycline and this cholesterol. But in the UK, it's totally different, entirely different. Same Acinetobacter, patient, ICU patient gets same Acinetobacter, but that Acinetobacter is sensitive to all penicillin group of antibiotics. So this different epidemiology. So they are statistically different. This one is different. So here, say if we do not have culture, strike period, sometimes we do not get cultures. So in those conditions, if a patient is deteriorating according to our local epidemiology data, we have to think about Acinetobacter cover with sometimes cholesterol, tigecycline, whatever it is. But in the UK, if you start this cholesterol or tigecycline, they will chase us away because it's sensitive. Even it's sensitive to amoxicillin. So this is very important. This one is very important. Good understanding of surrounding epidemiology. That's why we always say go through our guideline, antibiotic guideline, because our guideline, Sri Lankan guideline, is according to our epidemiology, but UK guideline according to their epidemiology. But we think, foreign countries. So for most of this one, we use Western guideline. Even for other diseases, I use Western guideline. But things for antibiotic is very important. Our local guideline is very, very useful. I will show our local guideline later. So which pathogens are most likely? So for example, patient now present with respiratory tract infection. So by taking chest X-ray and your auscultation findings, you diagnosed the patient as blood curve 65 score. You diagnosed as committee-acquired pneumonia. So committee-acquired pneumonia, it can be bacterial or viral origin. So if it is bacterial origin and if you want to start empiric antibiotic, what you should know? We should know about the common organism causing committee-acquired pneumonia. Then only we can start effective antibiotic, isn't it? So, say for example, committee-acquired pneumonia, I mean, most commonly implicated bacteria are Streptococcus pneumoniae, Mycoplasma pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae, Legionella, anaerobes. Say, for example, if patient's family say, yes, he aspirated, then we have to think about anaerobes. If we know this common organism, we can actually design the empiric antibiotic. So that's why to use antibiotic prudently, we should know which pathogens are most likely. And it's very common, respiratory tract infection, most common causes of respiratory tract infections are virus actually. So we have to think about influenza. Last month in Batticaloa, there was influenza outbreak in Colombo as well. There are influenza virus, respiratory syncytial virus, human metapneumovirus virus, Hanta virus. So in case of influenza, if we start antibiotic, that is useless actually. It will harm the patient. It won't help actually. So we should know about pathogens. Say patient present with mild cellulitis, just mild cellulitis. So we should know what are the causes of most common organism causing this mild cellulitis. Usually this is by methicillin sensitive Staph aureus, Streptococcus, mild cellulitis. These are the common organisms. Say for this patient, if we start meropenem or linezolid or vancomycin or high stuff broad spectrum antibiotics, what will happen? There's no benefit. It will lead to resistance. So usually for this kind of mild cellulitis, we use Fluclox. It's there in our guideline and foreign guideline also in other countries also, they just put Fluclox. So what I want to tell is pathogens are very important. So we should know about this common organism causing this disease. And for patient with committee-acquired or traveler's diarrhea, infection secondary to Salmonella, Shigella, Campylobacter, E. coli, Clostridium difficile. So if we don't know this common organism, we can start empiric antibiotic. So for this bug, if you put the patient is on cefuroxime, so for Salmonella, first generation, second generation cephalosporins are resistant intrinsically. So patient won't recover. So that is very, very important. So if you know the epidemiology, yes, you can say Salmonella, Shigella are very common in our country. So for this patient, I would consider ceftriaxone, Cipro, azithromycin. So empirically, and you'll get the stool culture. Right. So the next thing, assessing vulnerability of the patient. So patient might report a history of allergy in the past, even though no true allergy exists. It happens very commonly, very common in Sri Lanka and very, very common in the UK as well, because of the legal issue. Even if patient gets small rash, they label it as penicillin allergy. So what will happen next time patient, if he or she comes to the emergency department with septic shock, clinician will see, oh my God, this patient has penicillin allergy. Don't give any penicillin group of antibiotic. Nearly 60% of antibiotics are coming under beta-lactam. So if they can't give that 60% of antibiotic, so mortality rate is definitely high. So very, very careful before you label as penicillin allergy. Go through the history, examine. Sometimes that patient might be on. So when you label as this one Amox allergy, that patient 2 months ago, if that patient was on Cormoxiclav, so that is not true allergy, isn't it? So you have to go through the history, examination things, and if it is anaphylaxis, yes, of course, high risk allergy or anaphylaxis, we have to label it as anaphylaxis. But if it is just low risk allergy, just rash or just low risk allergy, don't label as allergy. First, you have to refer to our immunology department. You know, at MRA, there's an immunology department. Through your microbiology, Western province, you have a lot of microbiologists. Here only to Eastern province. So through your microbiologist, you can contact them, your immunology department. After confirmation, you can label. Before that, please don't label as penicillin allergy without knowing the factor, because it's highly dangerous to patient. Not allergy. Second time when patient comes with sepsis is highly dangerous. So keep in your mind when patient person with allergy, very, very careful. So patient with acute or chronic organ dysfunction, yes. So we have to think about antibiotic dosing. Immunocompromised patient, these people are more prone to get polymicrobial infections. So you have to be very careful. So here, so last time also 2 days ago, I saw a patient, bladder cancer patient, urine culture had grown 2 organisms, if I remember correct. Yes, 2 organisms. But usually for other people, immunocompetent people, we do not take it as significant. But here, yes, you have to treat because immunosuppressed population, there's a possibility polymicrobial. So when you even before you start antibiotic also, you have to consider this to use prudently. And drug interaction, for example, meropenem. So when patient is on patient with epilepsy, when patient is on sodium valproate, we can't give meropenem. It's contraindicated. Like there's so many contraindications are there. So you should know about interaction and side effects before start the antibiotic. And cost is very important. So when patient come to your private clinic, saying, I have wound that culture had grown, MRSA. If you start linezolid, that patient she won't come back to your clinic again because it's highly. The one tablet linezolid is nearly now 800 or 850 rupees. So they can't afford. So always think about socioeconomic status. And what is our next thing? Poor compliance. They won't take that antibiotic. So again, discontinuation prematurely, they will stop. So again, problem resistant. So socioeconomic status also very important to use antibiotic prudently. And identifying probable sites. Some sites of infection are difficult to penetrate with antibiotics. Giving the anatomy of the blood flow. So for example, central nervous system, we have blood-brain barrier. It won't allow to penetrate the antibiotics, most of the antibiotic. Penicillin, it can penetrate if it is inflamed meninges, penicillin can nearly 50% of the penicillin can go inside. But if it is not inflamed, it won't go. So, and for central nervous system infection, we can't give any oral antibiotics. So even we can give meropenem, ceftriaxone meropenem, but you have to give very high dose. So identifying probable site of infection is very important to use antibiotic prudently. So IV oral options. So I'll talk about bioavailability. So to decide, we have to decide, are we going to give IV antibiotic or oral antibiotic? Right. What are antimicrobials? Antibiotics for bacteria, and like that, antivirus, they are antifungal, antiparasitic agents. So there are a lot of this one antimicrobials. And what are antibiotics or antibacterial agents? Is medicine which can kill or inhibit growth of bacteria, or useful to treat or prevent bacterial infection. And examples of antibiotic, beta-lactam antibiotic, a lot of antibiotic come inside penicillin, cephalosporin, carbapenem. So nearly around 60% of antibiotic coming under beta-lactam. Nearly 70, 80 antibiotics are there actually under beta-lactam. And aminoglycoside, fluoroquinolone, macrolide, no, polymyxin, tetracycline, right? So as I told you earlier about that allergy, so nearly here, all these antibiotics are coming under beta-lactams. So if we label as penicillin allergy, we can't give any of this drug. So actually, mortality rate is really high. When penicillin group is the very best antibiotic, it has broad spectrum effect, and side effects are much fairly okay compared to other antibiotics. So Very, very careful when you label the patient as antibiotic allergy. Right. Choosing the correct antibiotic. To use prudently mean, what is that? To choose the correct antibiotic. So as I told you earlier, what are the probable pathogens? You should know about probable pathogens. If you know the probable pathogen, look at target. So prudently you can use. Antibiotic sensitivity pattern of these pathogens is very important. Your PG trainees are here, consultants I got here, so junior doctors here. So you should know some organism intrinsically resistant to antibiotic. What is that? For example, we'll take this Enterococcus organism, Enterococcus species fecalis, Faecium, Enterococcus ganiliarum, Falciparum. So Enterococcus. So Enterococcus is intrinsically resistant to cephalosporin, aminoglycoside, clindamycin, trimethoprim, cotrimoxazole, fusidic acid. Even I have seen some reports, laboratory reports, they put the ID as Enterococcus fecalis, but put sensitive to clindamycin. So where's the problem? Either ABST is wrong or ID is wrong. So very careful. So that interpretation of ABST is very important, right? So this is very important. And other than Western Central Province, there are no microbiologists. So you should be able to interpret that, right? Here, when microbiologists are there, before releasing the report, as post-analytical part, we see one by one. Our doctors, they know, see one by one. And if we find like this kind of ABSC, we immediately inform our medical laboratory technician. But if you don't have microbiologists, very, very careful when you interpret this ABST. And not only for Enterococcus, for all organisms, there's intrinsic resistant pattern. So you have to be very careful when you interpret. So actually, clindamycin we use to identify Enterococcus. Say Enterococcus morphology is there, and if it is resistant to clindamycin, we immediately say this is Enterococcus fecalis, right? And again, very important thing. Some antibiotics are in vitro, it is sensitive, but ineffective. For example, AMC producer. So this, what is this AMC producer? Acronym we call it as escapum organism, Enterococcus coliaceae, Enterobacter coliaceae, Klebsiella aerogens, Citrobacter frundi, Serratia marcescens, Providentia zosteri, Pseudomonas aeruginosa, Hafnia albi, Morganella burgoni. So these are MC producing organism. MC gene is there inside the organism, but on switched off position. When you give third generation cephalosporins or piperacillin tazobactam, Comoxle, what will happen? It will induce this gene and stimulate these organisms to produce AMC enzyme. Then this AMC enzyme will come out and lyse this antibiotics. So in vitro, when our MLTs, when they do, it will show very good sensitivity pattern. So they will report. It's not, if they report as sensitive, it's not their fault at all, because by looking at the plate, yes, it's sensitive. They usually laboratory sometimes it gives us sensitive, but very careful when you interpret. So if the ID is this organism, you can't give any sort of these antibiotics. And even here also I have seen some laboratories, they reported Citrobacter frundi sensitive to third generation ceftriaxone or cefotaxime. So if you start cefotaxime, initially 2-3 days, there'll be response. Patient will slightly improve, but all of a sudden there will be breakthrough infection. Patient again, he or she will start to deteriorate. So very careful when you interpret the ABST. And again, one example, 10 days old baby born prematurely, who was in PBU since birth, developed fever, had swollen and red joints. Blood culture had MRSS and gentamicin. Clinician put that patient is on gentamicin. So it's wrong. Laboratory fault also there because they reported gentamicin for MRSA. It's ineffective. MRSA you can't treat with gentamicin alone. So gentamicin is aminoglycoside mainly for aerobic gram-negative bacteria. So careful when you interpret. Sometimes you can see silly things on ABST paper, this one report, but careful, interpret, right? And some antibiotics are only for urinary tract infection. So group U is only for urine. For example, nitrofurantoin, Oflox, those kind of antibiotics only for this one. We report only for urine. So you can't use it for systemic purpose. Right. So pharmacokinetic and pharmacodynamic is very, very important to use antibiotic prudently. If you do not know pharmacokinetics, pharmacodynamics, very difficult to use antibiotic. So pharmacokinetics, you all know, simple pharmacology, absorption, distribution, metabolism, elimination, right? So here we talk about bioavailability. So bioavailability is why it's important for some antibiotics. For example, ciproflox, bioavailability is nearly around 96%. So 96 oral bioavailability 96% means like IV. So for ciproflox, we do not give IV drug. We always give oral ciproflox. Linezolid also like that. Try best to give this one oral because bioavailability is good. The UK, if we start oral IV cipro, they will jump. Pharmacists will jump without any indication because it's highly expensive IV cipro, nearly 100 times expensive. For example, oral linezolid also, oral linezolid, oral antibiotic is nearly around 800, but IV 12,000. So oral, same dose, oral 800 rupees, IV 12,000 rupees, the market now currently. So bioavailability is very important to use antibiotic prudently. And pharmacodynamic. What is pharmacodynamic? So for your antihypertensive, anti-diabetic drug, pharmacodynamic is what drug does to the body. So we here what we see antimicrobials, our part, what drug does the organism, what drug does to the organism, right? So pharmacodynamic is very important. So drug should reach the target site, should achieve optimal concentration, come into contact with microorganism, bind to target and remain there for sufficient time to exert effect, should resist inactivity or clearance, should not be inactivated at target site. So careful. It's not that difficult, but just I am going to talk about PKPD parameters. So I just give a brief idea about pharmacokinetic and pharmacodynamic. So this PKPD parameters, time over MIC, area under the core MIC, and Cmax over MIC are very important. So what is Cmax over MIC? That means Cmax is a peak. What is a Cmax? Maximum concentration over MIC. MIC is minimum inhibitory concentration. It's a laboratory report. If you request, we can issue this MIC. So aminoglycosides, it follows Cmax over MIC. What is Cmax over MIC? So amikacin, we give it as bolus. Why we give it as bolus? So for example, we'll take E. coli. E. coli is sensitive to amikacin. MIC is 1, right? So MIC 1. So what they say, if MIC is 1, ratio should be, Cmax over MIC ratio should be more than 20. Then only this drug will act. So if you give as infusion, it won't act. So if you give it as bolus, what will happen? So you can achieve that 20 or about 20 target Cmax. Then only this antibiotic will act on this organism. So very careful, don't give any aminoglycoside as infusion. It's very, very important. You have to give it as bolus, otherwise it won't work. Time over MIC. Time over MIC, this beta-lactams, clindamycin, erythromycin, linezolid, follow time over MIC. What is that? So time over MIC, so we'll take meropenem as example. So E. coli sensitive to meropenem, MIC 4. We'll take just example, take as 4, right? This MIC 4. So meropenem we give 1 gram 8 hours. So this time duration 0 to 8, right? So what they say, concentration at least 40% time of day should be above MIC for meropenem, for penicillin group of beta-lactam group of antibiotic. 40%. What is 40% of the time during 8 hours? 40% of the time means nearly 3.2 hours. So if you keep the drug concentration above this MIC for more than 3.2 hours, this drug will act on this organism. Otherwise, this drug it won't act properly. So that's why very important, meropenem, piperacillin tazobactam, penicillin group of antibiotic, you have to give it as infusion. Why I'm telling this, I have seen in a lot of ICUs patients, sometimes they have edema So immediately what people do, this patient has edema, so we have to cut down fluid. Meropenem, what's the volume they are giving? They dilute in 300 ml, so they give 300 to 900 ml they give per day. So you cut down, you dilute just with ml cc and give it as bolus. Is it correct? It's totally wrong. Just you are giving meropenem, but it won't work because it's time dependent antibiotic. 40% of the time of day should be above MIC. Actually, this is the point. This is a take home message. Forget about this Cmax over MIC, time over MIC. So time over MIC, some drugs you have to give it as infusion, some drug as concentration, and area under the curve over MIC mean. So what they say, this vancomycin, fluoroquinolones, glycolysins follow area under the curve MIC. Ratio should be more than 200. MIC is the laboratory report, so you can calculate the area under the curve and give cost it gives those for this area under the curve. So MIC is very important. Unfortunately, we are very, very poor, and we have machine for MIC, automated machine, but cartridge, and because of unavailability of cartridge, we can't do MIC for. In the UK, they do MIC for all organisms and all antibiotics actually, but here we select and do MICs. So if you request, of course, we can specifically give MIC. Right. So we'll move to 40 minutes here. We'll move to antibiotics requiring therapeutic drug monitoring. So again, it's very important for prudent use because therapeutic drug monitoring, some antibiotics it has narrow therapeutics index. For example, vancomycin, aminoglycoside. Here we should arrange this drug level because minor, if it is below the level, it won't act. Just above the level, it will cause high toxicity. That's why for vancomycin, when we give for infective endocarditis, aminoglycoside, when we give prolonged course, we always check this drug level. So therapeutic drug monitoring is very important. But for the beta-lactam antibiotic microlides, have you heard that we check drug level for meropenem? Usually we do not do because monitoring often not required. It has wide therapeutics index. So dilemma of dispensing. So biomarkers of infection. Biomarkers. This is also very important for prudent use. Biomarkers we use WBC, ESR, CRP, blood culture, blood lactate. So these are traditional one. And nowadays most of the laboratories they do procalcitone. Yes, it's useful because it has high sensitivity, high specificity, good positive predictive value and negative predictive value. And actually we can use it for antimicrobial stewardship and whether we can check whether antibiotic therapy is working or not. So half-life is a bit short than CRP, so very easy to monitor. But thing is, don't use this procalcitone, please don't use this procalcitone to diagnose sepsis. You have to see other parameters. But for the monitoring purpose, so antibiotic, once you start to decide the duration, actually is very helpful. For diagnosis of sepsis, there is actually no strong evidence because this procalcitone, it has false positive results still can occur. So major stressors, systemic inflammation, severe trauma, cardiac arrest, circulatory shock, surgery, burns, pancreatitis, all it can cause high PCT. But my point is, it's better than CRP. And what IDSA, Infectious Disease Society of America, IDSA, what it says, use this procalcitonin for antimicrobial stewardship purpose. So stop antibiotic. Yes, PCT, it was patient present with sepsis. He had other features of sepsis. Procalcitonin was more than 100. Now after 10 days of antibiotic, now it is nearly 1. So fine. Now 0.5 is fine. So you can stop antibiotic. No need to give prolonged course of antibiotic. So to use antibiotic prudently, we need this inflammatory markers, CRP, procalcitonin, but it has its own pros and cons. So careful when you use these antibiotics. So antibiotic adverse effects occur by 3 mechanisms. Antibiotic adverse effects occur by three mechanisms. By exaggerated side effects also very important. We should know about side effects because uh, to use prudently because of the side effects. If we sometimes if we put nephrotoxic agent and if we damage the kidney, so after that we can't use any antibiotics. So very important side effects. So exaggerated response is side effect. Immunological reaction also we can call it as side effects. Toxic effect because of components. So so antibiotic has desired effect, undesired effect. Undesired effect is this toxicity and side effects, and it can be dose related or dose unrelated. Usually, we this penicillin group of antibiotics are safe, and usually we take it as safe, but adverse effects are also common. Simple penicillin group of antibiotic can end up with anaphylaxis, so exfoliative dermatitis, erythema multiforme, and high dose, it can lead to renal impairment, coma, myoclonic jerk, and some side effects also high. Some ampicillin, amoxicillin clamic acid can lead to C. diff infection, Clostridium difficile infection. You know that colitis, pseudomembranous colitis, and carbapenicillin, ticagrelin, creates dysfunction and fluid overload. So we should know about these side effects as well. Cost. It's important to note that Sri Lanka 12.7% of total estimated health budget is spent on antimicrobial. So very careful when you use. So for example, amphotericin B. So when we start this amphotericin B for this one, mucormycosis. So conventional amphotericin B, just one vial is 5,000. But problem, it has renal toxicity. Liposomal amphotericin, for whole day you have to spend, for a day you have to spend 180,000 rupees. But if patient renal function is normal, for just I'm telling example, renal function is normal, if you can give conventional amphotericin just one vial for per day cost is 5,000. Because both are amphotericin. So we had to think about our economic situation and use this antibiotic prudently. And what's the difference between antibiotic and other agents? So this antimicrobial is resistant. So nearly, as I told you earlier, 2 decades ago, we used antibiotic, some more, So because of the irrational use of CR rate is very high. So this just for, one hospital. And other microbiologists also reported very high number of CROs. CROs mean carbapenem resistant organism, highly multi-drug resistant, highly infectious pathogenic organism. So a lot of deaths nearly per week, we lost nearly 3 patients purely due to carbapenem resistant organism. So actually, we talk about Palestine, Israel war, Ukraine, Russia war, but no one think about this war between this human and this organism, microbiology, battleground, no one thinks. So we are dying actually because of this resistance. People are dying, and we have no weapons. After that, after 1985, there's no weapon supply. We don't have enough weapon. If we mutate their cell and starts to attack, definitely we'll become an extinct species in this world. So careful. Why I'm telling this? Careful when you use antibiotic. And red light antibiotic, this 2016 circular health ministry has had issued this one. So red light antibiotics, you have to take microbiologist opinion to serve antibiotics. So these are red light antibiotics. This is under review very soon. It will come. They will ministry actually with College of Microbiologists. Now they are updating this one, and they will release very soon. And summary. So for the prudent use, first we have to diagnose that there's an infection. Find the site, focus of infection, choose the correct antibiotic empirically, dosing of antibiotics, find the causative organism, choosing the correct antibiotic, specific antibiotic, and duration of treatment is very important, because sometimes we see we know the target, but 14 days antibiotic or 10 days antibiotic enough, but sometimes patients on antibiotic for more than 20 days. So duration is very important. So unfortunately, we don't have clinical pharmacists. They are in the UK. They daily go through this tickets, and if it goes above beyond that duration, they immediately stop. So duration is very important. Monitoring and managing side effects. So this is our local guide, and I told you earlier, this is according to our epidemiologist. So local one. So it's very important. It's available online. Again, now our college, they actually reviewing this one. They will publish it very soon. This is, currently, we have this one, empiric antibiotic guideline. So for empiric guideline, definitely you have to go through this guideline, not foreign guidelines actually. So WHO aware there's access watch reserve antibiotic book is there. Actually, I have gone through this one. It's really interesting and really useful actually. Hope I have given some good idea about prudent use of antibiotics. Over to you. Thank you, and over to you, Samira.
Yes, thank you very much for your lecture, sir. It was very informative as well as concise lecture with all the information, including the basic mechanism of actions and the pharmacodynamics, pharmacokinetics, the evaluations, emergence of resistance, as well as the clinical aspects. So let's move on to the questions, sir. There are a few questions on the chat box. So one is, does old antibiotics like nitrofurantoin and penicillin becoming sensitive again because of reduced use in spite new more used antibiotics becoming resistant?
Yeah, actually, 100% correct, because nowadays people, they do not use, even in the UK also same situation. Nitrofurantoin and cotrimoxazole, Oflox, people do not use, even in the private sector, GP's clinic, people do not use. Because of that reason, most of the bugs, now actually we use nitrofurantoin. For urinary tract infection, we use nitrofurantoin because according to our, this one, antibiotic sensitivity pattern, most of the coliforms are sensitive to nitrofurantoin. Most, nearly around 80% of the coliforms are sensitive to nitrofurantoin because, so this gives clear, very good, actually, a very good statement. It gives clear idea. If we use rationally, if we optimize, so we can stop resistant pattern. It gives an idea, isn't it? If we overuse or irrational use can lead to sepsis.
Yes, so the next question is, if patient is on antibiotics for viral infection, can we stop it suddenly?
Of course. So people who are in Colombo, you can immediately send. So for example, if you are suspecting any respiratory viral infection, you can send it for PCR and you can get the results within 2 days. And of course, with that results, you can stop or go through with inflammatory markers. It's a very cheap one. So go with this CRP, WBC, or sometimes you can use, if patient has severe respiratory symptom, procalcitonin. If it is normal, you can immediately stop. Otherwise, just by clinical examination, it's sometimes difficult to differentiate bacterial and viral infection. That's why most of us, we start, just for the safe side, we start antibiotic. But within 48 hours, we have to optimize. We have to optimize by checking these inflammatory markers. And actually, in the UK, what they do, immediately they send a sample for take nasopharyngeal swabs and send it for all respiratory viral screening. And if it is negative for this adenovirus, respiratory syncytial virus, or influenza A, B, COVID, coronavirus, they stop antibiotic.
Thank you, sir. Next question is, what is the selection of antibiotics for trauma-related contaminated lacerations, open fractures?
Yeah, you can simply go through our guidelines that I already show you the empiric guideline. So it depends on the history. So where it happened. So if it is just roadside accident. So sorry, what is this? This is a roadside accident, and if it is contaminated, of course, we may need to give anaerobic cover, gram-positives, because gram-positive infection are more common. So gram-negative infection, it can happen, but later after hospital admission. But depends on history examination finding actually. So depend on the scenario. So there's no cut and right answer here. just contaminated wound mean? So where that wound, is it near the perineal area? Is it just below the knee joint? Or so all it depends on a lot of factor actually.
Thank you, sir. And there are a few other questions. I have shared the screen. These questions we have received in the pre-survey, sir. Most of the areas you have covered.
Yeah.
So, one thing is, are there any protocols regarding how to discard antibiotics?
Yeah, so there's no strict protocols, and you can read that waste management guideline. So it's published by the Ministry of Health, Epidemiology Department. So there they say do not throw antibiotics in the environment, because if you just wash and throw this antibiotic to the environment, what will happen? This organism can get exposure to this antibiotic and it can develop resistance, and from that organism it can go to, by transformation, transaction, conjugation, it can go to human pathogens as well. So we can't just throw. We have to carefully. We have to incinerate or when we discard these antibiotics. So you please read that waste management book which is published by Ministry of Health.
And there are another two questions related to the OPD setting. What is the place of using antibiotics in upper respiratory tract infection in OPD setting, and also regarding how to decide the duration of antibiotic treatment in the OPD setting?
Actually, OPD setting, I have seen a lot of people. So nearly 2 days ago, I met 3 patients. All of them, they said, all of them had viral infection, and for all of them were on amoxicillin. So if you can differentiate by if patient present with respiratory tract infection, you can simply diagnose viral infection in some cases, say sore throat just for 1 day, and running nose, just headache. So most probably it likes this one virus. So in those conditions, even amoxicillin is not going to help anymore, because here in Sri Lanka, amoxicillin resistance is very, very high. So just treat symptomatically. When OPD setting, please do not prescribe antibiotic for all these fevers. Just treat symptomatically. Only thing, your amoxicillin will help if patient has sore throat due to this group A streptococcus. So group A streptococcus sore throat, patient won't present with running nose and other viral picture. So if you strongly suspect group A streptococcus, yes, of course, you can first you take the swab and you send it for culture. Yes, of course, you can use very simple penicillin group of antibiotic, but please review within 48 hours. Please tell them to come after 48 hours. So once culture is negative, you can immediately stop antibiotic, or else if patient is fine, so then you can stop antibiotics. So we have to review for my referrals also. For each and every patient, I review after 48 hours, because we can start an antibiotic empirically, but we have to be very careful. We have to review and optimize immediately. Within 48 hours, we have to optimize the antibiotic. And what's the next question, Samira, about OPD? How can we decide duration of antibiotic treatment? Duration. Again, yes. Please review. So viral infection, if you strongly suspect viral infection, please do not prescribe antibiotic. If you prescribe antibiotic, please review. So why you prescribe antibiotic? You're suspecting bacterial infection. So to optimize, you need inflammatory markers here. So please review that patients with inflammatory markers. And if you take culture, please review. Because it doesn't happen not in I'm not talking about Batticaloa, Western Province or Southern Province. It sometimes happen in UK. People, they send culture and discharge the patient. When we see the culture, patient not there in the hospital. So this happens. I can't say it as false, but we have to correct ourselves. So always review. If you strongly so why you start antibiotic? You are suspecting infection, bacterial infection. So you start empiric antibiotic. So optimize that antibiotic. We have to review after 48 days. So please review with these inflammatory markers and culture results. Yes, Samira.
Then, so that's a question regarding the antifungals.
Yes.
If a patient who is in end-stage renal failure develop a widespread tinea infection which is not responding to topical antifungal, how can I manage the patient's skin condition?
Yeah, if not responding to topical antifungal means, so first confirm whether it is tinea or not. Take up skin scraping and send it to our mycology laboratory for diagnosis. That is very important, right? And thing is, if not responding to tinea infection, we may need to use systemic antibiotic, oral antibiotic. For tinea, of course, we can use Riciafulvin, or we can go with oral azoles as well. So first diagnosis. Have you diagnosed that person? Is he or she is here in this forum? Develops widespread tinea infection. So first we confirm that this one, because it can be some other, because we always confuse. Sometimes it appears as tinea infection, but it can be some other skin manifestation. So always confirm. You start and this one empirically before apply this cream. Take a sample. You have well-developed reference lab there in Colombo. They are very helpful. This mycology department extremely helpful, and they are the only people do fungal culture. So take the sample, send it for culture. 2 days you apply cream. So on day 3 you can get the culture results. So according to the culture results, you can optimize the treatment. Clinical diagnosis, of course, well, experts you can, but thing is, sometimes it can lead to a wrong ways. It can be this tinea not responding to antifungal mean, it can be something else actually.
Yes, so then there's another question regarding when patient is having several problems which require antibiotics, such as chronic wounds, UTI, how to choose most suitable one. And
Yeah,
also some
chronic.
questions. Sorry, sir. Some other questions about the targeted, how to use in the catheterized patients, the open fractures, and so
Okay.
on. Some targeted questions.
Okay. For the first question, that chronic UTI is very, very common problem. I encountered here in Sri Lanka and in the UK as well. So chronic UTI, sometimes people discharge patient with long-term antibiotics. Sometimes some patients antibiotic for more than 6 months. So guideline says for chronic UTI, that means recurrent. So that you mean chronic means this recurrent UTI. Of course, for some conditions, actually, we can give antibiotic, this one, prophylaxis. So we can treat with antibiotic, but should not treat more than 3 months. Guideline says, the UK guideline also says, don't prescribe antibiotic for more than this one. Find the cause. So there should be some cause, anatomical cause or some sort of cause should be there to get this recurrence. So we have to correct that cause. Then giving antibiotic. Giving antibiotic is temporary solution. So we have to cure the patient permanently. Sometimes patient with renal calculi might get this one. No point keeping that patient is on antibiotic. Remove the calculi. So anatomical structure problem might be there. So do the scan and refer this patient to this one neurosurgeon, right? So that is very important. But you can, if everything this one, you can treat with antibiotic, but please don't give more than 3 months. But we usually do not recommend for chronic prophylaxis. But if it is unavoidable, yes. For chronic wounds, again, surgical management is very important. So chronic wound means it can have this biofilm. Main issue is biofilm. What is biofilm? Organism, when they adhere to the surface, it forms film. It's a film because to protect themselves. So antibiotic or any detergent, it can penetrate this film. So without removing that film, you can't, glycine sort of film, you can't treat the patient with antibiotic. No point giving chronic this one, long course of antibiotics. So if you refer the patient to the surgical team, remove that biofilm, then you can, for chronic wound, you can apply. So chronic wound with slough mean you can apply enzymatic debridement agents such as Irapsol, or we can treat with silver acticoat. So like that, there's local wound management as well as systemic wound management. If it is very bad, we can use, of course, systemic antibiotics. But very, very important, microbiology golden rule is, eradicate the source. Second option is antibiotic. Without eradication source, if we give antibiotic, there is temporary solution and patient won't get permanent cure and it will lead to antimicrobial resistance. So for your next question, ceftriaxone is considered cheaper, effective antibiotic for prophylaxis antibiotic for, what is this? Type 3 fractures. No. Usually we do not give this one ceftriaxone for prophylaxis. And can it be used? No, we can't just use as prophylaxis. There should be evidence based. Initially, for empiric treatment, yes, you can start, but for fractures, if you are suspecting osteomyelitis, anything, you have to send. We have to take deep tissue for culture, and it should be according to that this one target. So prophylaxis means how many days we are going to give. There's no clue. So, and if it is ESBL, it won't respond to ceftriaxone. There are so many problems. Patient might get side effects, liver issues and renal issues. So, ceftriaxone, IV ceftriaxone is not recommended prophylactic treatment. First, initially you can start. Of course, you can start, but you have to. If it is an infected wound, yes, you have to take cultures and you have to optimize the antibiotic. You have to find the target and optimize the antibiotic. Is there any alternative with good coverage? So again, you go through our antibiotic guideline. That is very, very important. Please read for all of you, for PG trainees, for medical students, doctors. Please read this our guideline. So it gives very good idea for each and every infection. It gives very good idea about this empiric coverage. What is the best antibiotic for intraoperative use? So what is the operation? That is the first question. In Sri Lanka context, for clean surgeries, contaminated, is everything there in the guidelines. So clean surgery means, what is the clean surgery? Is it neurosurgery or thyroid? So what is the clean surgery? Clean contaminated, what surgery? Depends. So is there prophylaxis, antibiotic prophylaxis, surgical prophylaxis there? One chapter is there. Please read that chapter.
So thank you very much, sir. Our sincere thanks to Dr.B. Devakanthan, consultant microbiologist, teaching hospital Batticaloa, for his excellent lecture and the precious time. So if you have further questions, you can email us and kindly fill the link in the chat box and also give us your feedback. Then you can receive the e-certificate for participation. Thank you, everyone.
Thank you.